I had hoped that we would not need to have a conversation about COVID-19 and the festive and the fourth wave and so on, but here we are. I remember wanting to laugh but also not laughing when there was a video of that young lady who has a whistle, and someone said, Aish, when this young lady appears, we know that the fourth wave is coming. And my hope had been that because vaccines are now readily available to basically anyone who wants them in South Africa, we would be at a point right now where the overwhelming majority of South Africans, depending on which vaccine they'd taken between Pfizer and J&J, they'd either had their one or both shots. And I'm going to make a very clear declaration here. For me, I am not neutral on this issue. I am vaccinated. I took the Pfizer vaccine, so I got my two shots. Everyone in my family, at least in our nuclear family, in the rural sense, which is about 30 people, we are vaccinated. And I harassed everybody who is not vaccinated, including my mother, to eventually vaccinate, and they did. And that's important because I was just not in the mood, at least not in the family, to have to deal with somebody who's in hospital that we can't even see, and then have to potentially deal with the possibility of them passing away. That's one reason. The second reason is that so many people are suffering as a result of the lockdowns and damaged economies and so on. Real people who do not have work, who are not going to have work. People are losing their jobs still, and people who've lost their jobs and don't know if they will ever get them back or get the same quality of job. Thirdly, I'm worried about the children, the younger people that at some point they are going to start getting sick and we are going to have the same problems. There are so many reasons to vaccinate, but I will talk about my own reasons for vaccinating more specifically. I believe that I have a duty to myself and to my loved ones to make sure that I am protected. And secondly, because I use public services, and by public services, I mean anything that is offered to the public, including by the private sector, such as going to the shops and so on, I have a responsibility to ensure that as far as I can, I do not put anyone that I come across in retail organizations and elsewhere at risk by not vaccinating. Especially that when we sit in restaurants, we take our masks off, and the people that wait on the tables and bring us drinks and so on have to talk to us without masks on, because generally we do not keep the masks on when we are at the restaurant. I feel I have a serious duty as a human being to make sure that I do not put those people at any more risk than they already are. So this is not one of those conversations where I'm sort of deliberately neutral and I ask questions. I'm vaccinated. I am pro-vaccination. And I want to make that clear. I am pro-vaccination, and I encourage everyone I come across who has this conversation with me to get vaccinated. That said, this is not just a conversation about vaccination. This is a conversation about COVID-19 and the fourth wave and so on. And before I bring in the prof, I will use an example of General Norman Schwarzkopf, who was the U.S. Army general who led the U.S. and other armies into Iraq in 1991, I think it was. So he later was diagnosed with one of the cancers. I do not remember which one. And so he was explaining to the journalist that he has read everything that he can read on what he had been diagnosed with, because he said he takes the same approach to cancer, to any enemy that he has to face. It is really important that you understand as much as you can about the enemy. And our enemy right now is COVID-19 and everything that relates to it. So what's really important tonight and in the future is that as we learn more and there are variants and other developments. As many people as possible have the most up-to-date information, and that information is from experts who know what they're talking about, and not people who do their research on their cell phone while standing on the queue at Pick and Pay. So it is for this reason that at the prompting of my friend Tessa, we are talking today to Professor Mosa Moshabela from the University of KwaZulu-Natal. Good evening, Prof.
Good evening, Songezo, and everyone listening. My warm greetings.
Thank you very much for agreeing to be part of this conversation. I will make a public announcement early on, which is the Prof has got to be at another panel at 8 p.m. But I am sure by then he will have answered any and every question that we need answered, so that he can have time to have a glass of water and have a comfort break and then join that other panel. So thank you very much for making time in what is going to be a marathon evening for you.
My absolute pleasure.
Prof, let me ask you a very basic question. What do you do? I deliberately didn't read your CV. I know you don't swim. I know you don't swim, at least not as a job. But but what I do know is that you are a scientist. You are a health scientist in particular, and your CV is very long. And one of the things I also appreciate is that on the website, there is a long list, longer than my arm, certainly, of papers that you have published and the papers that are going to be published. So, but for people like myself who are not very into these things, just tell us what you do.
Yeah. So, thanks for that. And I also, before I start, I want to just welcome everyone. And I see there's a lot of friends and colleagues who are experts in very specific fields of health who are present today, and I'm really happy to see that, because I'm sure they will help us to field some of the more specific questions. But for me, I'm trained as a medical doctor. I did my MBCHB at UKZN. And then I went to, because of the times that we were in, I got involved with the HIV. So I had to do some training, specifically in HIV. And I had to do a 2-year diploma in HIV, just so that I can be able to provide the services and the care that needed to be provided at the time. And I was playing quite an active role there. And then I specialized. So I should say that when I left medical school, I wanted to be a surgeon, and specifically a trauma surgeon. And then I just happened to graduate at a bad time when HIV was rife and we needed to get involved and support. And many of our seniors who were not trained in HIV were not comfortable to do the work. So we ended up doing the work. So somehow then I needed to find something else to do. And at the time, I thought that I was just passing time, but I chose to do family medicine and primary healthcare. So I specialized for 4.5 years in that. And it was a really good decision, because I think overall I see myself as a generalist. Even though we register it as a specialty, I still think that I am a generalist. I like to connect the dots. And work with complexity, which is why I find that if I have to work in a very specific discipline, I find it confining. But I always like to draw from all these disciplines and pull the threads together, connect the dots, paint the picture, and translate that into something that has societal impact. And I think through that process of training in family medicine, then I realized how, and I think also influenced by HIV, I realized how it was really important to understand research, to understand how to critique research. They used to give us these research articles and say to us, critique this article, and they will give us sort of a structure to use. And then at the end, decide whether you're going to adopt the recommendations of this article into your practice. And every time when I got to the end of that, I got stuck because there were so many things that, so much nuance in the article and many things that I didn't understand that make it difficult to have confidence in the recommendations that were made through those articles. And I think that's how I ended up becoming more interested in public health, because I wanted to go deeper into the field of research and science, and that's what I did. I did my PhD in public health. I attended some training in epi and biostats in the US at Hopkins. My PhD, I did it at Wits. My family medicine, I did it at Medunsa. At the time, it was still the joint University of Limpopo before it became Sfako. And then I also got a Wellcome Trust fellowship for 4 years that essentially allowed me to do any further training that I needed to do to complete sort of my research competencies or portfolio, so to speak, in terms of training. And so I went to the London School of Hygiene and Tropical Medicine to do an MSc there. And even though a lot of my courses were mostly around epidemiology and biostats, I ended up taking other courses in population health. So eventually qualified with an MSc in demography and population health. So I would say that that is sort of my background and my job. Up until December, I was the Dean of Public Health, School of Nursing and Public Health at UKZN. I am a professor of public health, and currently I hold an executive position at UKZN, which basically means that I have to oversee research and innovation in the whole university as Deputy Vice Chancellor for Research and Innovation. Let me stop there. Thanks.
Prof, thank you very much, in particular for the background, because one of the things I often remember is that when I think it was 11 March 2020, where I used to work, we had a press conference, and there were questions about the virus. I think back then it was still it had just been declared a pandemic by the World Health Organization. And I think that was the last or second last day that I came to the office. And I remember thinking, we'll be back in June. and June came and went, and we were still not back in the office. And as it happens, I actually never went back to the office. Your background is important in the combination of factors that of things that you've done, areas of study and qualification, and also your current position at UKZN, because in this conversation we are going to also be talking about a cross-section of issues, because as a public health issue, it's not just the doctors that deal with it, it is also the political authorities, it is individuals, it is employers, and so on. So it is a bit of a complex issue. So thank you once again for agreeing to be with us. What I'd like to ask, Prof, as a first question is, can you just explain the changing nature of the information that becomes available? Because one of the things that I think undermines trust in the medical authorities is where people say, oh, but this is what you said last year. Now you're changing your story. Now you said we must vaccinate, and now we must take a booster shot and so on. What is it about viruses in general that makes them change at all? And how do they change?
Yeah, I mean that's an important question. I think there's two parts to your question. One is, the fact that viruses will evolve over time, but the other part of your question is that our knowledge itself will evolve over time. And I suppose this is something that in health and in science in general, we grapple with all the time, the changing knowledge. And if you think about it, if knowledge did not advance in research and science, we will come to a point where we know everything. But we don't arrive at that point, which is why this field is so important, and the sort of economy of building knowledge has become so important, and advancing knowledge. And that's why, we have people who have to do PhDs because they add new knowledge to everything that we do. And I will tell you about my experience. When I was a young doctor, I think around 2002, 2003, when we were setting up HIV services. HIV services became more formalized around 2000 and end of 2003 in terms of ART, when we adopted the policy, and in 2004 we launched the national rollout in South Africa. One of my frustrations there was the explosion of knowledge. There was constantly something new. When you think that you have grasped something, there's something new that has come up. Information that you held like a few months ago, it's outdated, and guidelines had to be updated regularly as information came out. And there was something that we were taught even in medical school. They said, by the time a textbook is published, it is already 2 years outdated. Just as a rough sort of guidance that we are dealing with an environment where information is constantly evolving, and we have to be able to find ways of keeping up. And I made reference to this issue of journal articles, because it was really when you keep up with journal articles that are constantly being published that you are now able to keep up with the new information. But not everything that is published is something that you need to take up. You need to be able to critique it. And so we then have to link the production of knowledge to policy. Policy is a different process which requires for all of the different pieces of knowledge to be synthesized. And we start to look at the weight of the evidence. It's not just one thing that comes out. We have to constantly review the weight of the evidence and the direction that it's taking. And it is frustrating. When we started off with HIV care, we said we provided antiretroviral treatment to people with CD4 count of less than 200. And we changed that to 350. We changed that to 500. We eventually said, well, anyone, whatever CD4 count, you will be initiated on treatment. And I remember we did a study on this, and one of the patients coming in, when we introduced the universal treatment whereby your CD4 count did not matter, saying to us, it's so unfair that you are now saying that anyone with any CD4 count can be initiated on treatment, because my sister died with a CD4 count of about 300 and something, at a time when you only initiated people with a CD4 count of less than 200. Now she can get to initiate the treatment at any CD4 count. If this was the case at that time, her sister could have lived. And that was a very painful feedback, receiving it from a patient, because then what it says, it was essentially an indictment on the sort of changing knowledge that we as scientists keep bringing forward in drips and drabs. And so when it comes to COVID-19, you can imagine, well, it feels to me like what we experienced then with HIV was just the same thing, but on steroids. The explosion of new information from everywhere. And there is no way even I can keep up with all the different pieces of information that is emerging every single day. And so, we have to then grapple with this constant information. And, the challenge of taking information from elsewhere, applying it to your own context, it's also another challenge. There is so much complexity. When you now have to take it into policy, there are so many other factors you have to consider, including resources and so forth, that you have to consider when you go into policy. So this is a hard field, Songe. So it's not an easy field to work with where you have to make decisions that affect people's lives, and you constantly have to weigh the weight of the evidence. And at some point, yes, you might make a mistake, but you hope that the mistake that you make does not cause harm. And that's what we want to avoid. Our effort here is constantly to say, let's make sure that the benefit outweighs the risk constantly. There is no way that we can provide 100% certainty. That's the nature of science. There's no certainty. But always what we want to do is to make sure that the benefits of what we put forward is going to outweigh the risks. And so just the point that you ask about the viruses, I think that in the same way, we know that life evolves. It evolves for all organisms in the world. And the same thing with all the agents. In epidemiology, when it comes to diseases, we look at broadly, the triangle of three things to simplify it for ourselves. One is the agent, and the agent can be the virus in this case, but it can be a bacteria, it can be a parasite, it can be something else. Now, the other one is the host. The host is the person who gets infected. And so that's where we look mostly at the immune system, because then the whole thing around infectious diseases, be it HIV, be it malaria, be it TB, it's really an interaction between the agent or the virus or the bacteria with the host. And the properties of the virus that we would study mostly through virology, and the sort of characteristics and attributes of the host that we would often study through immunology to understand the immune system of a person. And so those things then begin to interact. But there is a third part to it, which is the environment. All the things that we can do in the environment, be it season, be it interactions, be all the things that are modifiable in the environment that can influence that interaction between the agent and the host, are the ones that we try to manage. And you'll see when we say that distancing, we're trying to manage the environment. When we say that, okay, healthcare services, we're trying to manage that, to modify the effects of the agent on the host. So essentially, the people the host will also evolve over time. The agent will evolve, the environment will evolve. There was a time when these viruses it was not easy for them to spread because we did not have as much flying as we do today. But now we're flying all the time, so it's easy to get an agent from China or from somewhere else and take it to Europe, take it to Africa, take it to India, and so forth. So that is all the environmental factors, Songes. And so if we can break it down that way, then it starts to help us to think, to understand that we're not just here dealing with an issue of a virus. We're dealing with an issue of a virus. We're dealing with the host. We're dealing with the environment. All the issues that have to do with politics and so forth, they're all in the environment. So the viruses themselves then will evolve over time. And as they evolve, essentially what then happens is they try to adapt to the environment so that they can survive. If we accept the theory that their goal is to be able to survive, and even when they infect a host, the theory is that the intention is not to kill off the host, because if they kill off the host, then they will die as well. So they need to find a point where there's a balance between their existence and the existence of the host, which is why even in our bodies we have so many how shall I call it, agents in our bodies. We've got a lot of organisms in our bodies that don't necessarily cause harm, because they've essentially gotten to a point where they've built a normal, healthy, living, mutually beneficial relationship. And viruses also, I think that in general, we understand them to try to survive, not necessarily to kill off the host, but at the time that they begin to encounter the host, that relationship may not necessarily be balanced. So sometimes they would cause a lot of diseases. And so with coronaviruses, there are 7 types that we know. And the 4 of them essentially cause mild disease, like upper respiratory disease, mild symptoms, and we know about them. And so they can cause most of what we call common cold can be caused by these 4 types of coronaviruses, as well as other viruses like influenza and so forth. But there are three others of the seven that we now know of. The SARS that happened in 2002, the MERS that happened in 2012, and now the SARS-CoV-2 that happened in 2019. These ones, they cause more severe disease. And so, part of the problem then becomes, over time, we would hope that as they begin to engage with us, it's either they disappear or we find some sort of a balance where they don't necessarily cause disease. You can imagine that even the ones that are now kind of infecting us with mild disease, at some point, they may have caused more serious disease. We may not know, but it's also possible. So essentially, the way we look at it, Songes, is that the viruses exist because of our interaction with our environment, mostly to do with interactions with animals around us. And that's why the whole field of zoonosis, of studying the diseases that are transferred from animals to human is so interesting. And the people who do that work are the ones that will often warn us about the possibility of new agents that might infect people. And so they will evolve then their own genetic material over time. And the field of evolutionary biology goes into a lot of detail around how viruses change over time. And part of what we are seeing in the so-called variants is that sort of evolution of the virus over time. And where it's going to go, we don't know, but we understand that it does occur. We understand that it's a necessary form of survival for it to occur in theory, but in the process, it can cause a lot of harm. And hopefully, eventually, it is not going to be harmful or it can disappear.
Prof, so what you are saying to us is that in respect of the first part of the question and the answer is that the responsible thing to do for public health authorities is that when there is a virus or disease that is obviously causing harm to the population, it is important to let the public know that there is this virus. Secondly, to also set out the context to say, we are warning you so that you can take all the precautionary steps, one, while we are also trying to figure out more in terms of, firstly, how this virus works, and secondly, what the best way of dealing with it medically is going to be. But essentially, in the meantime, please wash your hands, please wear a mask, please wipe down surfaces and so on. So in essence, you're saying that is what happened last year and continues to happen. And therefore, we should not lose trust when more information becomes available. And basically, we are more informed and smarter, basically, in how we deal with it. Would I be correct in putting it that way?
You've put it so well. And I think the part that you are emphasizing is the one around communicating the information early and probably as it becomes available. But in the process, also acknowledging what we know and what we don't know, what we are still working with or working on. And I feel like with Omicron, we kind of saw that happen live much better than we saw in the past with others, where the information became available and immediately, the information was about, we know this much, but we don't know this. We're still looking into this. We expect that we will know in about 2 weeks. And as information becomes available, that information then becomes made available. The problem that is the issue that's missing in your summary, Songezo, is the part whereby it becomes either difficult to explain things that people don't understand or to answer questions that people have, because that information is not yet available, or essentially there is an erosion of trust around the information that is being provided. So with the origins of SARS-CoV-2, we saw a situation whereby 4 theories emerged, that it could have moved from an animal into a human in a spillover event, or it can move from a bat into another animal before it went into a human, another type of spillover, versus the theories that have to do with the possibility of the virus having leaked from the lab and so forth. So then it becomes a problem, because then if there is not enough information to either confirm or dispute some of those theories, then they can actually lead to people saying, well, are you telling us the truth or not? And that's where I think, for me, the struggle for us with COVID-19 has been. We saw it with HIV, but not to the same degree that we are seeing it now with COVID-19.
In fact, you mentioned, I'm going to tell a very short story, which relates to HIV, by the way, and that is there is a sort of very popular theory, or there was theory that said that HIV was created by the Americans in order to kill black people, basically. So I've been reading a lot on misinformation and disinformation, and the history of how that whole thing was seeded into the public domain is actually really interesting, in that it was first planted in a newspaper in India, and it didn't gain any traction. And then years later, it did. And in the time of the internet, it just flew much faster than it did. I'm paraphrasing this story. It's a very fascinating story, by the way. The point being that in this day and age where we can travel across time zones in less than half a day and be in another continent, and secondly, we can communicate with people on these platforms such as Twitter and so on, I would imagine it becomes ever more difficult to put out the most accurate information out there in such a way that people know very quickly without being confused. Now, bro, what I want to ask is this. So there was in the last week, which caused huge controversy, this variant, which same President Macron of France, I'm sure he sometimes feels like he's being trolled. But this latest variant, there was a term that was used, which was South African scientists were the first to sequence it, right? And that said to me, and I want you to correct me if I'm wrong as your answer, that said to me, basically, you have an evolved version of the virus. You need to basically try and work out how this thing works and understand, and basically be able to draw its makeup on a sketch and say this is how it works and this is how it is different from what we know. So basically, we were the first ones to figure out what is going on. Why is this sequencing important? Can you just explain the sequencing, and also why is this sequencing important to inform public health and scientific responses?
So, yeah, I think this is also where, Sanges, I'll probably want us to invite Richard Lascelles to come and comment in some detail around the process of sequencing. But the issue that is important is this, is that you must know the enemy that you're dealing with. And to know the enemy, you must study it in every detail. So I imagine that, if you have to fix an engine and you don't know what's wrong with an engine, you take it apart into pieces to understand it, every little piece to understand it. And so when it comes to sequencing, be it of DNAs or RNAs in virology or in molecular biology or in evolutionary biology, it is important for scientists to be able to see the sequence of the genetic material of the agent. And all of the different parts of it, when they put it in the sequence, eventually it will be able to tell them what kind of agent they're dealing with. And if there are changes, they're able to see, previously we saw this sequence, but this has changed here. So why is this change here important? And it is those things that they then pick up. And because they also don't just study the changes in the sequence of the DNA, they study what those DNA sequences or RNA sequences, what sort of behavior in the virus are they linked with? So that becomes really important. So the sequencing is our way of studying the agent and understanding the genome or the genetic material of those agents. And when we understand it, we know what type, we can classify it. We can then begin to predict what kind of behavior it might have, what relationship it has towards other kind of agents. So we will say that, okay, this is in this family, but it departs from this family because of this changes. And so that is important. But I also want to just tell you a brief story around this, that I think it's important for people to understand that, you know, the work around coronaviruses started a long time ago. You know, the first outbreak of SARS happened in 2002. And there's a gentleman, and I guess this is public information I can share. His name is Peter Dusk, who is the head of EcoHealth Alliance in the US. I met him in 2019 at a workshop where we were trying to work out how to essentially bring the conversions around communicable diseases or infectious diseases and non-communicable diseases. But I didn't know a lot about his story until last year, when all of these issues around coronaviruses emerged, and the role he and his colleagues, including the colleague in China at the Wuhan lab, you know, the kind of work that they were doing. If people are interested in kind of getting a little bit more information, it is really helpful to read some of those articles that are published around the experiences of this team and how the work that they did in discovering the coronaviruses in bats and how they began to link the possibility together with Zenglin, I think, from the Wuhan lab, the possibility that these coronaviruses may have emerged out of bats. Again, a relationship between animals and humans. And a lot of work that they did to identify these different viruses and sequence them over time. And when and of course, many of the research, including the basic science research, to, as you said, to understand the type of the agents they're dealing with, the virus they're dealing with, the possibility of interventions, the possibility of clinical manifestations, all of those things, all that work began back then. But when 2012 happened with MERS, the Middle East syndrome, when that happened, respiratory syndrome, when that happened in 2012, then the work actually happened in earnest around coronaviruses. And so that's why when we got to a point where we identified SARS-CoV-2 or the problem with COVID-19 or what became known as COVID-19, so much happened quickly because the researchers who were already working on this research that started for a while, essentially came together and provided the sequence of the agent very quickly, and immediately, you know, within 2 months' time, some of the trials began to happen. So that process of sequencing becomes an important part in helping us to understand what we are dealing with and what we need to do. And we have to do it continuously over time. Let me pause there, Songezo, and invite Richard to add any comments on the issue of sequencing.
Yeah, I hope you can hear me. Good evening. Good evening, Songezo. Good evening, Prof. Good evening to the listeners. I mean, I think.
Sorry, Richard. Can I ask you maybe to start here? So please, you could deal with this issue, but I want to ask you maybe a question before that, which is, why do variants form? Why doesn't it stay the same?
I mean, I think simply, as Prof explained, the virus changes in order to survive. Yeah, that's all that matters. The virus is just surviving. So to survive, it needs us. It needs humans at the moment, or other animals, because the virus passes from person to person. And that's really important just now, because it really highlights probably what's going to be the key feature of this Omicron variant is that to survive at the moment, this virus needs to be able to infect people that have some level of immunity. Because we know that many of us in South Africa have some immunity. We've either been infected or we've been vaccinated, or quite a lot of us have probably had both. We've been infected and then we've got vaccinated. So when you look at the population as a whole, the levels of immunity are quite high. So for this virus to keep spreading efficiently, which is what it needs to do to survive, it needs to be able to get around some of that immunity. And we already see that now with this variant, that it's clear that it's got better at infecting some of the people who've had a prior infection. We can see that now quite clearly in the data, that the number of people being reinfected is going up. And it's more than we've seen before with the other variants. So it's simply, as I say, it's the virus is changing, as Prof said, because the immunity in the population is changing. And one important, just going back to the sequencing, one really key thing to just remember is that it actually wasn't just sequenced here in South Africa. It was sequenced almost simultaneously in Botswana. And that's important because it highlights that there are teams currently across all of Africa doing this sequencing work. And one of the things that many people have been working very hard on in the past few months is really kind of strengthening the capacity to do that sequencing in many African countries so that we can continue to track this virus, but also be better equipped to track other viruses and bacteria and TB and things. And in terms of the sequencing here in South Africa, in simple terms, we did it. We set it up at the beginning of the pandemic because we knew how important it was going to be to track this virus. And that's because we have a lot of experience in South Africa of tracking the evolution of other pathogens. And we think particularly about HIV and TB, but also other infectious diseases. So we knew it was going to be something important because we knew that understanding how the virus changes makes a difference to what you do to control it. It can inform your public health action that you take. And so it was the government, the Department of Science and Innovation, that invested quite heavily in the sequencing program. And we built this network of laboratories around the country linked to the diagnostic labs, the labs that do the PCR testing. And that's kind of what's allowed us to track this virus and to detect these variants as they've unfortunately emerged over time. So I hope that gives a little bit of background, but essentially it's just going back to your very first kind of discussion with Prof, that it's just about tracking this changing virus to give the information to kind of inform your public health action and decisions.
All right.
Thanks.
Thank you very much, Richard. Now, Prof, and maybe you, Richard, as well. I mean, Prof, you'll let me know if you need Richard to come in. So from what both of you have said, I'm beginning to understand this issue in this way, that you will have a virus as we've understood it, a variant or the main strain that we're all dealing with, beta or whatever. And so what we on the medical sciences side, after the sequencing, we work out how best to deal with this in terms of vaccination on the one hand. The virus, on the other hand, keeps coming across different people with different immune makeup, with vaccines and so on. It's also working out a way in which to survive. And it keeps finding new ways. if I understand variance that way, would I be correct? I'm going somewhere with this question, but I just want to know if basically this is the battle that happens. We're trying to figure it out and get as many people as possible vaccinated. It's trying to survive. It's looking for and keeps finding new hosts, and it keeps evolving to make sure that it does not die. And therefore, that is how variants form. Would that be correct? And therefore, when there is a vaccine, it gets smarter eventually. Would that be accurate? And please correct me if I'm not.
Yeah, so I think it's accurate. I think the one thing that I just want to clarify, I don't want to, we don't want to create an impression that, you know, the virus is sinister and colluding and kind of planning behind the scenes. No, no, no. I think in a way, we are presenting the issue this way, the way you are summarizing it, in order to simplify it for purposes of explanation, but not necessarily that there is a sort of intelligent process behind the scenes that is happening from the side of the virus. I think if you think of it, it's really about selection. If you've got different types of viruses that are emerging and all of them are being sequenced, some of them we would say that they are not significant changes. They are not going to be a problem, but some of them become important. And that's why we even have, variants of interest, the ones that are on the watch list. That might be threatening, and then variants of concern. Once we say this one is genuinely having characteristics that we should all, make sure that we respond to it. But essentially, by the time we arrived there, there's been so many other kind of variants that have emerged in the process that have been sequenced, but they did not necessarily grow to become really problematic. And what it means is that if you think about it, say you've got about 10 variants growing at the same time, the one that is going to survive is the one that's going to succeed in getting around, say, the immune system or the interventions that are put in place and continue to grow. Then it will begin to dominate. It's not because there was any sort of meeting to say you are the one who need to overcome this or that. No, it's just because the others fail to succeed through natural selection or a process of selection, that the one that is able to succeed, it will self-select. And it becomes more of a natural process that way, that begins to allow it to continue to survive in a different form, so to speak. And I hope that helps to clarify, Songes.
No, thanks, Prof. It does. So let me just somebody who's asked to speak, to ask a question. Tessa, please go ahead. Tessa, please unmute and speak. Okay, thanks.
Thanks, Hans. So my question is related to this, the idea of a new variant and vaccination. I've been working with COVID comms. We've been trying to communicate some of the issues around vaccination and the new variant. And the big question that kept coming up for us is there a relationship between high rates of vaccination or high rates of people not being vaccinated and new variants forming? Is that an important question? Is there an actual relationship between these things? Is there a matter of saying if we get to a certain level of vaccination in the population, that it increases or decreases the risks of new variants, particularly ones of concern?
Yeah, let me ask Richard to address that, and I'll try and put it in simpler words after that, because the question you're asking, Tessa, it's a question that has been asked several times, and there is so much nuance to it that we really need to be careful in how we frame it. On the one hand, I think that, we can end up giving an impression that vaccination is a problem. And on the other hand, we can end up giving an impression that not vaccinating makes you guilty. We need to be careful in how we address this. This is an important question, and we need to address it, and let's talk about it. But let's understand and pay attention to the nuance that I believe is involved in how we understand this issue. Richard, would you like to go?
Sure. I think we understand quite well now that these variants emerge wherever there's high levels of transmission of the virus. So wherever the virus is spreading at quite a high level. And as Prof said, this kind of process of evolution and mutations is just the natural process as it passes from one person to another and on through the population. These mutations happen as a natural process. And then a variant may emerge that has some evolutionary advantage at that point in time. And that will be the variant that then is able to spread more efficiently in that population. So, as Prof said, it's a difficult discussion because it's kind of the opposite of what some people argue. So some people argue that these variants are emerging because we've rolled out vaccines and because the vaccines put that immune pressure on the virus, but actually it's the opposite. It's that these variants are continuing to emerge in places where we haven't got good control of the virus, so where we haven't got high enough levels of vaccination, and where and where our other public health measures struggle to control the virus adequately. And so that's really critical to understand because it's very easily taken the wrong way by people who want to misinform us and want to try and create kind of harms from the vaccines. But we understand this virus much better than we did last year. We understand how it's evolving, and we understand how vaccines work. And so I think it's important to try and get this clear. And it is a difficult thing to communicate. And I will hand back to Prof to try and improve my attempt to communicate that.
Yeah. I think let me go to the politics before I come to my response. I think the politics have been that there is a blame game. People who are not vaccinated are responsible. People who are vaccinated are responsible, and it's not helpful, that debate. And if I were to be diplomatic, I would say both groups are sort of right, so to speak. But we've got choices to make. So if we say that the virus will mutate on its own, that's what it does. It will mutate. It's not because of people. It's not because of interventions that it will mutate. It will mutate on its own. And it mutates more when it's got an opportunity to spread. So let's say we don't put any interventions, then it will mutate more. And whatever is the fittest variant, it will dominate. But we also know that the moment we respond to it and we put measures in place, be it growing immunity from infection or growing immunity from vaccines or whatever interventions that we put in place, it will self-select. The one that is able to evade those interventions will be the one that self-selects to dominate, just like we are seeing now. But also, again, it will endeavor to make sure that it doesn't kill off the host. So essentially, our options are: we don't vaccinate, we let it run rampant, but in the process, it causes so much morbidity, so much mortality. We don't want that. We want to intervene. As we intervene, at some point, we may have certain variants that begin to dominate that can escape the immunity in order to survive, which is why being half immunized is a problem. But also what you want to do is, even when you are fully immunized, you might have that variant that wants to avoid that immunity. That does not mean that because a variant emerges that tries to evade immunity, that tries to keep on surviving, that we must stop fighting it. Because if we don't fight it, then our other option is to face the consequences of the virus causing disease and mortality. And for me, that would be my more diplomatic response to this, Songezo. And I am saying here that it is not helpful to try and focus on who is responsible. It is the virus will try to evade the collective effort that we put in place. Even if we were just using hand washing and ventilation and so forth, all of those interventions, even if we were just dealing with infection immunity, we let people die and whatever, but eventually we have a lot of immunity. The next variant will try to evade that immunity in order to survive. So we need to make sure that we get to a place where we overcome the virus without too much loss and too much damage, which is why it's important that, you know, if we're going to have immunity, let's have it from vaccines rather than from infections, because out of those infections, then we end up with a lot of people that are going to have long COVID, a lot of people that are going to end up in hospital with diseases, and some of them may die. So I would answer it that way, and I hope, Tessa, that sort of helps in putting this issue into perspective, which is why I said there's a lot of nuance to it.
Right. Prof, so before we move to, because I do want to talk about vaccine mandates, but I think before we get there, I'm going to ask this question. And then after you answer, I'm going to give Ms. Barbara an opportunity to ask a question as well, and maybe one or two people. But here's my proposition. Is it that the best thing to do, the best and most humane thing to do, assuming that you do not want to just let people die and hope that eventually whoever couldn't cope with the virus has died and whoever can has lived, and therefore we're fine, hopefully, in the future. Because you don't want to do that. And we've seen what happens when you've got no strong intervention from a medical science perspective, when bodies were piling up. The other alternative, or the most reasonable alternative, is to develop a vaccine. And once you have developed that vaccine, it literally becomes a race against time to make sure that you vaccinated a certain percentage of the population, at least, hopefully everybody, so that as the variants develop, the population is basically generally stronger and will not get hospitalized. And so, in a way, you get to that point of equilibrium where we are able to live, have a peaceful coexistence between ourselves and the virus without anybody getting sick or seriously ill, in the way that we kind of live with the flu. Would that be correct?
Absolutely. And I think if there is one thing that I have always said, you know, for me, I have no personal interest in people getting vaccinated or personal agenda. I've got none of that. But that is essentially the issue, is that if we had 5 years, you know, or 10 years, and we can afford to wait 5 years or 10 years, you know, we will give people ample amount of time to decide whether they're going to vaccinate or not, to try different things. No problem. There wouldn't be that much of a rush. And I always say the one thing that makes a difference in all these debates, in all these discussions we are having around vaccines, is the issue of time. That's the only difference. That's why we always say, you know, we fought so hard at the beginning of the year to have vaccines with the hope of getting as many people vaccinated before the third wave as possible. And we saw the benefit of that, at least among healthcare workers, where the burden of disease and death was extremely reduced amongst healthcare workers, because we were able to cover a lot of them before the third wave. But we did not see the same in the general population. So when we're coming out of the third wave, we're saying, let's push to make sure that we've got as many people vaccinated before the fourth wave. And again, that was the time to try and reduce the negative impact of the virus when we have a surge of infections. It is a race against time. It also explains why we are so upset with people who are, you know, in the global north, who are not supporting a fair distribution of vaccines to the global south, to all the countries, including many countries in Africa. Which is also why, I was saying that even in South Africa, we need to be careful not to do the same thing that the global north is doing, where we are hoarding vaccines and our fellow African countries do not have access to vaccines. Because each person that you vaccinate before the next surge of infections, it contributes a lot in terms of providing benefits, reducing morbidity or disease burden, as well as reducing the burden of death. That's really what we are trying to do. And as we are saying, you're correctly putting it to say that what we want to do, at least, if we're not going to have all the benefits of having the vaccines and every intervention that can help us perfect ventilation, we don't have all of the things that we need. As a compromise, let's just try and achieve a goal whereby we spare as many lives as possible, that we don't have people who are crippled by the infection with this virus that's so damaging to various systems of the body whenever people are infected. We want to try and get there. There are other reasons that are immunological that have to do with the immune system to basically suggest why we have focused a lot more on protecting people from severe disease and hospitalization and death, and kind of sounding like we are giving up on the issue of mild infection and just any asymptomatic infection, which we are not. But I think it's more, again, a question of us negotiating those risks and benefits. That's really what we are trying to do. We're trying to make sure that we can absorb some risk, but at the same time, make sure that we get the most benefit that we can in the process. And time there, it's really the issue. I would accept that. Thank you.
All right, thank you, Prof. Let me not monopolize the microphone. So can I please request all our commenters and people who ask questions, let's keep it succinct. The Prof has got to go, and I'd like to release him at 19:45. So we've got 40 minutes, and I want to get through as many questions as possible. One. Two, I'd like to deal with the issue of vaccine mandates, plus some of the steps we can take to protect ourselves during this festive season. Ms. Barbara B., go ahead.
Thank you so much, everyone. Good evening. Maybe my question has come a little early. Prof, kindly in layman's English, explain the difference between mandatory vaccination, compulsory vaccination, and forced vaccination. Thank you. In layman's English, please, but in terms of public health. Thank you.
Thank you, Ms. Barbara B. We are going to park this question because it's our next segment. But thank you very much. In fact, it's one of the questions I was going to ask the Prof to address. The next person, I think, is Katie.
Hello, it's Katie speaking. Apologies for the delay. Thank you so much, Prof, and thank you so much for the hosts and everyone else for this really important conversation. I think it's really important. I do have an Australian accent, but I live in South Africa. I'm also someone that contracted COVID in the beta wave here in South Africa and have not recovered due to long COVID. So I'm really grateful that you've brought up long COVID several times. And also, I would like us not to focus just only on the vaccines, which might be an important factor, but as we've seen over the past week or two, the repeated reinfections. And as you know, there are many people that are immunocompromised in the country. We don't know the effects of this virus at this point, and I'm concerned that the narrative is quote unquote mild around this specific variant. But as you know, and have really, poignantly pointed out, that perhaps we should just focus on the mortality rates, but also those people that might have, less severe complications in the initial stages, but also might have long-term effects. And particularly now that we're seeing that people are getting reinfected, that were infected during the alpha, beta, and delta waves. So I would love to hear your thoughts on that. And again, I recognize as a fellow scientist that this is really early, but I would love for the world to communicate that we are in the early days, and I would love us to personally focus on things other than mortality rates, and I'd love to hear any of your thoughts on it. So I'm very grateful for your time. Thank you again.
Thanks, Katie. Prof, would you like to deal with that?
Yeah, I think that is an important point. We just got results from the team that's essentially being analyzing this data on the South African data on issues of reinfection, and it is, I would say, the first set of data that we are getting that is showing that when you look at this new variant of Omicron, the rate of reinfection is about 3 times what we saw in the waves that were dominated either by Delta or Beta. And that is the first signal for us to say that the Omicron variant is able to evade immunity in some way. In the study, they were not able to make a distinction between people who are reinfected, only because it is able to evade immunity, or whether these people were also vaccinated. They were not able to make that distinction. So hopefully we will get more data that's going to answer the question of immune escape around vaccines, and that is the next question. And also, just there's some early data that's looking at transmissibility that's also showing that it is highly transmissible, but we're still trying to quantify by what margin. The same thing with escape of the vaccine immunity. We need to understand by what margin. The way I make sense of the issue of immunity in general is that, and I haven't found the best way to articulate this in terms of immunity from infection and immunity from vaccines. And the way I make sense of it in my head in simple terms is to say that, when people get immunity from infection, there isn't any regulation of the dose of infection or the inoculation. So we accept that there is variations in the type of immunity that people develop. Whereas with vaccines, there is sort of a regulation of the dose to optimize the response that people have in immunity, which is also why we can see when it wanes, by what margin. It's been measured, all of it. Whereas with infection, it varies between individuals, it varies time, it varies variant. There's so many other things there that are hard to actually depend on infection immunity. And so we've had this debate about infection immunity and vaccine immunity. And we also tend to focus a lot on antibodies when we talk about waning immunity, whereas antibodies are the sort of arm of the immune system that kick in at the point where you are exposed. When you are exposed to infection, they kick in, they try to neutralize the infection. It's almost like, okay, besides the skin and other kinds of defenses, it's almost like it's the first line of defense. Whereas if the virus can get through that and end up infecting your cells, then it activates the other side of the immune system. And you'll often hear people talk about cellular immunity or T cells and so forth. It's easier for scientists to relatively easier to measure antibodies, but it's not so easy to measure the T cell response. They are working on it. There's some data that also seems to suggest that actually the T cell response is longer lasting, is durable, it will be able to protect us from severe disease. But I think the issue is almost that, that infection, for the T cells to be stimulated, it's almost as if that infection needs to get in first, which is why people might end up with some sort of mild infection. This is again similar to that issue of that we were discussing around this issue of variants and how they emerge and versus immunity, vaccination, and so forth. This issue of the two arms of the immune system is also very nuanced. And the question of whether you are protected from that first line of exposure or infection, and your immune system is neutralizing everything before it can even make you sick, or it breaks through that barrier and then it causes some kind of infection, and then you are then protected from severe disease by the T cell response. This is a nuanced discussion that I'm trying to simplify so that people can understand that when you hear scientists say that, yes, you might still get infected, but you may still be protected from severe disease, they are speaking about largely by this sort of two arms of the response. And the nuanced discussion, of course, is more complex than that, but I would simplify it in that way for people to understand. But indeed, once someone has had a mild infection, we know from previously that people who have had mild infections, they still had what we call long-term sequelae, these symptoms that are chronic and long-lasting. And it's almost as if we are saying mild infection might not create a burden on the health system, but in the short term, it may not. In the long term, if those people continue to have the long-term sequelae and they require all the scans and tests that people have been doing to try and help them, it can still create pressure on the system in the long run. And it also affects the quality of life of those people. It affects general well-being and productivity. In my view, I understand that the national policy is to try and protect the health system from this burden of severe disease, which I agree with, and it's important. That's the priority. But I think, as Katie has indicated, we have to think already now to say, for people who are having mild infection, what would be the long-term sequelae of that? And what would be the burden of that in the long run? We might find ourselves in a situation where we've got a much larger number of people that are having all these sort of chronic symptoms and chronic conditions that Katie has referred to. And there is, I think, Dr. Spogazi, who's been really dealing a lot with these issues of long COVID, and Nhlanhla as well, who, they've been trying to hold a lot of seminar and build awareness around long COVID. It's something that we've raised several times on Twitter as well. But, Songezo, it's something that we have to talk about. I know it's not a priority right now because we are just so worried about severe disease, but we must not ignore it. We must not think that we can get away with mild infections when there is a possibility of long COVID. Let me pause there.
Thanks, Prof. Actually, I have a friend who is struggling with long COVID, and she's in and out of hospital. Another friend occasionally gets some of the symptoms. She'll have bouts of coughing, extreme fatigue, and so on. And she was one of the first people that I know who got COVID last year, and to this day she's still not 100%. So it is a real issue that perhaps at some point we're gonna need to talk about. I'd just like to ask, before I move on to the next person who wants to ask a question, Prof. The fact that people, and I want you to say whether this is true or not, the fact that you have reinfections, one, and secondly, you have instances, and that is with this Omicron variant, that you have instances where people who have already vaccinated get infected again. I know two who treated themselves at home basically with basic flu medication, and they are now fine. The fact that we have got those instances, does not mean two things. One, the vaccines were premature, such that at some point we will have an all-weather and any day into eternity vaccine that cures everything. So one. The second thing, it doesn't mean that the vaccine was fake news. Is that correct?
Yeah, so in my view, and I'm going to explain the context of my answer this way, that again, when you're dealing with a public health threat, like what we are dealing with, you've got to balance the risks and benefits. And again, time is an issue here. You know, we can wait. We can wait to develop a perfect vaccine, and we can wait 10 years to do it. In the meantime, we let COVID run havoc and run amok and complain that the vaccines were premature and so forth. And we think they're premature based on a historical lens of how long we understood vaccines to take, and not really taking into account the technological advances that we have and the preliminary work that had already been done ever since we had the SARS of 2002. Nevertheless, I think the issue here for me is that from a public health perspective, it's so important that we strike a balance between having a perfect vaccine and also getting benefits from it at a time when you have the problem. When I say that, I will never, ever support an intervention that brings harm to a person. There has to be compelling evidence scientifically that people are safe from any public health intervention, first and foremost. And secondly, that the margin of benefit that you have from the intervention outweigh the risks. And the moment we have a product that is able to make a difference in our lives when we are faced with that problem, we got to go with it. I'm sure people have heard the video that Mike Ryan of the WHO often repeats, that in a pandemic, you've got to move quickly. And some of the decisions that you're going to make may not be perfect decisions, but you've got to move. Because it's only when you move, then you can be able to protect people from infection, protect people from disease, protect people from death, and save as many lives as possible, and benefit from whatever intervention modality that is available to you. Use the tools available to you. And you would have seen, we've thrown everything at it. We've thrown hard lockdown even. And in retrospect, many of us are saying, well, maybe that was not a great idea. But we also know that if we didn't do anything, we were just going to be looking at each other and a virus will be running amok. We don't want that. I think it's important, Sonia, and colleagues, that we understand the importance of public health interventions from the perspective of us getting benefits from them, and those benefits must outweigh the risks. It may not be perfect as we would like, but the benefits might also outweigh the risk. A good example, just as I close on this point, is how South Africa decided to go with one dose of Pfizer for people 12 to 17 years of age. It was a very classical example of how a country similar to, I think, the UK decided to go with a dose regimen that showed that the moment you go into the second dose, you start to see increased risks for a small margin of benefit. Yes, of course, we would want to go into the second dose, but when we start to look at the margin of risks and the margin of benefits, we can see that the margin of risks begin to not be as compelling as you would like, and not be as compelling as you see with a single dose. So they decided to go with a single dose. And for me, I was actually very impressed by that when I saw that data. And I was like, this is public health in action, where you are constantly weighing the benefits and the risks. And yes, it might not be an ideal decision, but on the balance of it, you have managed to actually get the most benefit you can extract from an intervention for a minimum of risk. And so this is the hard work that I was referring to of public policy decision making, where we look at the data and we say, this is the best that we've got right now, and we're going to use all the tools that we have, and this is how to combine them, and this is how much we're going to use them, and these are the benefits we're going to get from them. Right now, we don't get the benefit of no infection. The vaccines don't create a halo around a person and protect them from exposure. Vaccines don't necessarily are not able to protect people with that first layer to neutralize completely. Most people are protected from that, by the way. It's not everyone who's vaccinated who is going to get mild infection. It's some people. And there is that margin, of course, that we are talking about of immune escape, and they will escape the antibodies. And that's what we're talking about. But they will have mild infection because there's also the T cells that are going to kick in and protect a person from severe disease. So there is a balancing act here, Songezo. That is nuance that we are working with. The message that we are sending is not necessarily pulled out of the hat. And this is this is not a zero-sum game. It's not a matter of you either have it or you don't. It's always a spectrum. It's always a margin of benefit and a margin of risk that we are weighing. At the end of the day, whatever we recommend, it's going to have a greater margin of benefits than risks.
Thanks, Prof. So I'm going to give Dr. Mayayise a chance, and then Mfundo, and then we're going to move to the mandates. Gentlemen, please try and keep your comments and or questions very succinct, because we need to finish in about 20-25 minutes.
Thanks, Ngozi, and thanks, guys. The only gripe I have is to first allow Prof. Mosa Moshabela to speak first, because he's a very eloquent speaker and very good at describing these concepts. However, from my side, I'm more on a clinical side, and I'm very limited because I work with cardiology, which is the heart disease. So I will come across those who have had some form of heart involvement or suspected to have, to be able to get cleared. So on our side, the issue of long COVID, yes, it's something that is we are seeing a lot of, especially after the previous wave, the third wave, where people now still manifest with symptoms of the chest and so on, and then also the issue of vaccinate or don't vaccinate. On my side, it becomes very, very easy, because our patients were the ones who were really coming with a much more severe burden of disease. They were the ones who were dying the most because they already had pre-existing heart disease and stuff. So my recommendation generally is that my patients, soon as they are stable, soon as their conditions are controlled, and then they go and get a vaccine. And then we haven't really seen, from the cohort of patients that I haven't really seen ones who come with the severe kind of side effects that we hear on the discussion. I appreciate the issue of unmasking this issue of variant and the evolution and the mutations of the viruses, the reason behind it, and the immunology behind it, and the benefits of. Hopefully, I will get to the point where we get to tease out a little bit more about the vaccine-mediated immunity and the infection-mediated immunity. I appreciate a lot, and I benefit a lot from this. Thanks, Ongezo.
Thank you very much, Doc. Mfundo?
Mfundo got disconnected, Songezo.
Yeah, he did. I've just reconnected him again. I've seen this happen a couple of times. Okay. While we're waiting for him, for the sake of time, let us move to mandates, Prof, because there is this conversation about whether we should have mandates, and I guess this is a sort of a new term in South Africa, because In our language, something is either compulsory or it's not. So you get to a traffic stop. They want to see if you've been drinking. It's not negotiable. You submit yourself to that test. They'll even take you to a facility, or etc. etc. If you're traveling to Uganda and Kenya, like I have, you must take a yellow fever vaccine and a malaria vaccine. If you don't, they're not going to let you in. Simple as that. But I understand that in this instance, it's a bit of a nuanced issue. Can you just explain the basics of vaccine mandates? And also, if you can, maybe touch on the ethical considerations involved.
Yeah, so I think this is an important issue. For me, one thing that I've noticed in all these issues around COVID-19 from February last year, when we got involved and we set up a team at our university to essentially bring different specialists together. Richard was one of them. Our clinical virologist, Nokanya Msomi, who's also here, was also one of them. There was several others from different disciplines. One of the early problems we saw was this issue of how to communicate the messages, the language. It was one of the first problems. And I remember even back in March, one of our biggest gripe was that, we are seeing all these preparations of, the health system, the country was setting up hospital facilities. They were setting up in terms of laboratory testing, even helping other countries to prepare. And they were setting up around the border and so forth. But the question that we were asking was, if you look at examples of countries that have been through SARS or SARS-like coronaviruses, pandemics, the likes of, Singapore, you realize that their approach is much broader. There has to be a component where you are promoting health, you are building awareness, you are engaging people. And yet what we were seeing is surveillance that people are not even aware of, and also preparing for health services. And people were not even aware of that either. But to a large extent, the part where you prepare the population for something like that, and you raised this earlier to say, when you discover something, it becomes important to communicate it. That part was lacking. And it's sort of one of the reasons why we took it upon ourselves to start finding ways to communicate these messages in a lot simpler terms so that people can understand and break down the science and synthesize the science, and realizing that, there is a scientific debate happening, which is a lot more nuanced. But when we get into the public, then we end up with a situation whereby the scientific debate is spilling over, raw as it is. And so it causes a lot of confusion for people. And for me, this is something similar, where we saw a situation whereby what should have been a policy debate that involves people concerned and a cohesive agreement, a consensus that is reached, and a cohesive agreement on the messages to be communicated to the public, that part didn't happen. We saw the debate happen in public. And that for me was very disturbing to actually see. And it happened back in September, and I even wrote a thread on this, and just saying to people that, look, we need to be careful that there is so much nuance to the issue of mandatory vaccination that if we simplify it or oversimplify it too much, we're going to confuse people. And that's what happened. And right now we are at a point where people are looking at something, as you say, that tends to fall in the ethics domain, being discussed in the general public, using language that is general language that we use. And for me, generally, when I speak to people, more generally, when I say mandatory or compulsory or forced, it looks like there's no difference. And I wouldn't blame anyone who's speaking in public without necessarily drawing any differences. But from a public health ethics framework, and I know Barbara said I must not speak from public health perspective, but from that framework, if I have to translate this into simpler messages, I would say that when you think of forced vaccination, you're thinking of something that is forced on you regardless of your choice, regardless of your rights. And I imagine a person being held down to have a vaccine injected in their arm, kicking and screaming. And those kind of things have happened because in the past. And we've got lots of case studies around, people being forced to do things against their will, against violating their rights. And we have come so far in South Africa that we don't want to go back there. We don't want to have a situation where rights are violated. But there is the second layer, which is the compulsory vaccination. And compulsory intervention is something that is compelled often by law. And of course, I use these words to simplify the explanation, and I want to put a disclaimer that in different disciplines, you might find that those words, the exact meaning of those words is different. But let's forget about the disciplinary lenses of science. Let's just focus on making an explanation that is easy for people to understand. Compulsory is compelled. And an example I think of here is when a person is involved in a car accident and the police come and they find that the person is suspected to have been drinking, they can take that person. They can take the person to a doctor and they can force. And I mean, I've seen this where people are brought to us in casualty for us to draw samples and they don't want it. It's not even in their best interest for them to extend their arm for us to draw blood to test alcohol because it means that it's prison time. And so, but they have to do it. They're compelled by law. It's compulsory. It's not like they're being forced and held down, but they're compelled by law to do it. And they will do it. Eventually, they extend the arm and a blood sample is drawn from them. And that's the example you referred to. And so that is compulsory. Now, I separate that from mandatory. And mandatory, in simple words, I think of it in terms of vaccine mandates or any mandates that we have in society. And we say that here you have a combination of incentives and penalties. And all of these things are happening in the context of going beyond your individual rights to start thinking about the collective benefit, the collective good of everyone else. When someone is compelled by law to have their blood drawn, they're not doing it for their best interest. They're doing it in the best interest of everyone else who's involved in that scenario. So public health begins to do that. It moves away from what in medicine we know as bioethics framework that looks at an individual rights, autonomy, and so forth. It starts to look at the public health ethics framework, which is much broader, and it includes issues of proportionality of risks and benefits, includes issues of social justice, includes issues of human dignity, the collective good issues. So then when you now get into mandates, we are saying that, yes, you will have your own space to do your own thing. But if you have to go into the space that involves other people, then you must understand that you must do things that is for the good of everyone involved. So those penalties and incentives and benefits are designed around that. So an example that I use here is sort of the anti-smoking mandate, whereby we came from a point where, people could smoke anywhere and everywhere, but we knew secondary smoking was a problem. It was causing a lot of lung diseases. So it was not in the interest of everyone else for a person to smoke. But we did not really stop people from smoking altogether, but we said you cannot smoke in the plane. You cannot smoke in the airport. You cannot smoke in this restaurant. You need to be outside and so forth. So then you're building a system such that people who are smoking can be accommodated in a different space, and those who are not smoking can also be accommodated. And if you're now wanting to encourage, and there was a lot of pushback, by the way, this was South Africa getting to this policy passed. It was not easy, but we have now arrived in a space where we are used to this. We understand the importance of not inconveniencing other people with smoking. There are other mandates, Songe, so like we talk about people who travel to African countries, they know about the yellow fever mandate that, you can't arrive back in South Africa if you don't have the yellow fever mandate vaccine, or go and be accepted in another country without it. So these things are things that are then put in to make sure that we can have public benefit. It's the collective benefit of most people, as opposed to just focusing on the individual right. And if you look at it from an individual rights perspective, we can say that you have your individual right, but you also have responsibility. And we're trying to balance that. When we come to a point where we are dealing with a pandemic that's causing harm to most people from a population perspective, we then say, look, what is the responsibility of each and every person to contribute to easing the burden and the pain and the harm that comes from that kind of a problem? And mandates are helping us to do that. And I must qualify this to say, in my own personal view, mandates are not meant to be permanent in this case. I think that if South Africa can be able to get to a high coverage, you're going to hit a point where there are people who are vehemently opposed to vaccines, that, well, no matter what you do, they will not agree to it. There's no point of mandates then, because a strategy to get them vaccinated, they will say, you better take me kicking and screaming. It's forced vaccination. We don't want that. But for me, from a public health perspective, I will be very comfortable with us having a very high coverage of vaccination, because I will know that we have done everything we can to protect South Africans. And any harm that comes from that, or any risk that comes from that, we need to be prepared to live with it. We need to be prepared to live with those consequences. But where we are at the moment is not enough. We can't be at 40% of adults, or 25, 30% of the general population, when we know that at least 60% of South Africans are willing, and another 20% are just on the fence. And all of them, if they are convinced we are well beyond 80% of coverage of vaccines, we've got enough vaccines. What is left really is for people to make that decision. Every time we waste in taking a vaccine, it means that people continue to be exposed to risk. It means that we're creating the space for the virus to spread. It means that, there are consequences to those things. And it's different when we don't have an option. If we did not have vaccines, like this time last year, we did not have an option. Vaccines were not an option. So we had to kind of work with the tools that we had at the time. But right now, vaccines are also a tool that we have. And the issue here really, Sonia, that you have to address, and I think address with relevant people, is that many of these public health issues have been hijacked by other agendas, be it political, be it economic, be it other kinds of agendas are at play here. You think that, sometimes I think that I'm having a public health debate with a person, only to realize that actually there is a political concern behind what a person is raising as an issue to do with the public health intervention. And that adds a layer of complexity to the debates and discussions. And we don't often go deeper into the nuance of those debates. And I think that we have to face the bull by the horn and say, what are the other agendas that people need to raise and discuss? Let's sort them out. Let's not let them spill over into the public health debate, because that puts people in harm's way.
Yeah, no, thanks, Prof. Look, I will share quickly an experience I had. I tweeted about it earlier, and I was actually buying a sausage roll a couple of days ago, and the gentleman who was serving the sausage roll was talking to another customer and saying, "Mas Jovi Sangengan," which means they're forcing us to vaccinate. So I joined the conversation, and he was very unhappy. That he had to vaccinate at his work. His mask was below his nose as he was serving the food. And I was thinking, my goodness, surely this person has to understand that in what they do, they have to think about people like me and anyone else that they come across that they're serving food to, but that appears to be lost. I will say this more directly, Prof, because you're very diplomatic. There are certain prolific peddlers of misinformation in South Africa. Some of them are on this space as we speak. And as we have seen elsewhere in the US and other countries, their purpose, and I've studied misinformation quite closely for years, their purpose is to make it impossible for public policy decisions to be made in general. They sow confusions, they introduce fake information, they twist facts in order to confuse people so that consensus where people agree on the way forward because we are a democracy cannot be achieved. And they are sophisticated in doing that because they are very eloquent. And that is the risk that South Africa and the rest of the world is facing, as we see in America, where there is a death cult, where there are people whose sole purpose in the media and elsewhere appears to be to sow doubts in people's minds about vaccination when they themselves are vaccinated, because their purpose is to demonstrate a political point so that their view of whether the incumbents, in whether it is Biden or anybody else in another country, is a failure. We know who those people are. And some of them are on this space as we speak, Prof. And they are sending laughing emojis. Prof, what I'd like to move to, because we're running out of time, is so we've got this Omicron variant, and infections are going up. The positivity rate is high, and so on. I kind of tend to feel that they are, the government can only say so much, right? And we have to take care of our own health and take certain measures to protect ourselves. Can you just share with us how ordinary people like ourselves, whether we're vaccinated or not, what measures we should take? I'll give you an example. In my own family, there is umgidi in the extended family. Some of the members in that family are not vaccinated, so I am not going. But that's me. Can you share, Prof, in terms of what some of the things we can do?
Yeah, Sangezo, I think maybe start by saying that we've been working on this pandemic from the beginning, and we've been receiving information and exchanging information with people throughout the world. I mean, when I first came across SARS-CoV-2, COVID-19, sort of seeing it in a country, it was in the first week of February when I went to Singapore for another meeting. But Singapore was one of the countries that was affected by the SARS pandemic, and they had developed systems. And when I was there, I saw a situation that told me that, in South Africa, we are nowhere near ready. They had 12 cases at the time of COVID-19. And then they had their first community transmission, a case where they did not know, the person had not traveled, they did not know what the source was. I saw a shift in how the whole country functioned. So they had this sort of similar to alert levels. And this is also, this idea of alert levels is something that we also adopted early, but we adopted it from Singapore. And they use 4 levels. And essentially, the moment they have got community transmission, they needed to move from the yellow level or level 2 to level 3 to the orange level. And the last one was red, and that was when there's widespread infections. I saw a country just shift in sync. You leave the hotel, and the hotel, it's like an open space where people have your sanitizers and so forth. You come back in the evening after they've made an announcement. There is security, there's a table, there's everything, every check, everything. The whole system has shifted. And that was happening throughout the country. And I looked at how that country shifted, and I was like, we are not ready. And I came back because of that community transmission. The advice was that, we should quarantine. And I had to come back and quarantine for 14 days. after that. And I felt the pain of quarantining at home because there was a remote possible exposure, in Singapore, which, if I looked at the odds, I would have said the odds were very low. But we don't have that mentality in South Africa. We are not there, and it's so unfortunate. It pains me because we have so many other burdens of disease, with HIV, with TB, with other things now, malaria and other chronic conditions. We're just not in a space where health and well-being is something that we put high on our list. And when we are that vulnerable in that many ways, we even have the space to just take things for granted. And yes, it's South African humor to laugh at everything, even painful things. But there's a point where we have to actually just pause and ask ourselves questions to say, but what are we doing? Because every infection, every death that happens, as an infectious disease doctor or physician, or that could have been prevented. That infection could have been prevented. And if that person was in Singapore, chances that they would have lived was very high. But they are here. And our healthcare system is not designed to protect people from exposure to infection. It's designed purely to help you once you're sick and very sick. Which means then the responsibility to protect ourselves from infection and to protect ourselves and care for ourselves when we have mild disease, that is our responsibility. And we have to help each other. We have to protect each other as South Africans. And we have to make that decision. If we don't make it, the world will continue to laugh. I mean, you are deprived of vaccines by the global north. And when your vaccination rate is low and you have identified a variant, they lock you away. But no one is going to take responsibility for the fact that, they hoarded vaccines. We are not in a position to have government on its own defend and protect us. We are not there. The systems that we have are not equipped. So we have ourselves, Songes, and friends and colleagues here. We have to help ourselves and help each other. And, we've always, we laugh at the fact that, the world admires us for having a strong human rights constitution, but let's not abuse the rights that we have. The world admires us for having Ubuntu value systems. Let's call on that at times of crisis, even if we'd like to have the banter of laughing at each other and teasing each other. But this is not the time. I have never, in this whole 2 years, I've never been as concerned as I am about a variant. I think that, at the beginning, I was very concerned because I was concerned about our readiness. But I think after the first surge of infections or the first wave, I felt like actually we might just be okay. Even if we're going to take a knock, we didn't have vaccines, we didn't have much, we will probably be okay. And when beta came, I was not as concerned. I was worried, but I was not as concerned. I always said, let's not panic. And even when Delta came, I said, let's not panic. Let's be rational. But I look at Omicron, and I look at the pace at which it's growing, and I look at the carefree attitude that we have as South Africans, and I'm just like, this is not good. I'm worried. And I don't even think that the sort of goodwill and the goodness that we had at the beginning to work together, we have it now. We don't have it. And we're going to pay a price for it. And by the time the price has been paid, we'll just look back and say, well, that was that. Because it will be too late. We were not going to have an opportunity to go back and reverse it. So people wonder why I spend so much time engaging people. I do it because I want to know that at the end of the surge, I've done everything I can to be able to provide as much support that I can provide for people to be safe. I have not had COVID. I've been vaccinated. I follow precautions to the T. And it's not because I'm pro-vaccine and I'm against people who don't want vaccines. As I said, in my book, there's always an accommodation for people who don't want vaccines. I've always said this. But at the same time, I think that it's too reckless of us to think that we are above what this variant can do and the consequences that we can have if we don't hold together. So people know what to do. It's a choice they have to make, Songes. It's a choice that we have to make, not only for ourselves individually, but even for strangers, people we don't know. I say that if you don't want to vaccinate for yourself, vaccinate for the person that you work with, or vaccinate for the person in your family. If you can, vaccinate for the stranger as well. But this is the kind of values that we have to tap on, because we are so vulnerable. And at this point, the world is also isolating us. And South Africa, in my view, actually has a duty to already provide the leadership and support of other countries in Africa. We're not even ready to do that. And yet we are privileged. We've got the privileges that enable and allow us to be able to do that. So I would say, Songezo, that everyone who's here, they know what they're supposed to do. I'm pretty confident we've done that work. But I think what's really missing is the choice and the commitment, and really kind of for us to stop squabbling about silly things. Once the fourth wave is back, we can come back to our squabbles, and that's fine. But for now, let's just pull through, work together, and get past this. I'll stop there. Thank you very much for the honor of the invitation, and again, all the colleagues that were present to also provide support and inputs. Much appreciated.
Prof, thank you very much. I am going to release you, even though I am going to make some closing remarks. So if you want to drop off and prepare for your 8 o'clock, that is absolutely fine. I want to thank you for your public service, and I also want to thank you in the research itself and the work that you do. Plus, always being available, always being patient. I have seen people troll you on Twitter and ask you if you've done your own research and so on, but you are always diligent, you are always patient, and I really appreciate that, because at the heart of what we need to do is to try and communicate with people with as much respect as possible. So thank you very much. I'd like to make some closing remarks, and I apologize to several people who wanted to speak, including our regular Mfundo, that we couldn't ask. But I'm going to make a couple of remarks. The first is this: that this is a pandemic. This is not an ordinary flu, and I think we all need to have a higher sense of duty as human beings. One of my biggest concerns for me has been the elder members of my family that I wasn't able to see, and even now that I am able to see them, I do worry that they might get infected, and I might be the carrier of the virus towards them, and they've got several underlying conditions which might make them vulnerable, and therefore it is very important for me to take all the necessary steps to make sure that I lower the risk that I pose to myself and to them, as well as other members of the public. So there's a point to be made about a higher sense of duty for all of us. The second thing I want to say is that there is an organized effort globally to peddle misinformation against vaccination for whatever reason. We see it in the United States of America, we see it in Europe, we see it in South Africa as well. It is highly sophisticated and it is highly organized. And it is important that we understand its techniques, and its techniques are to keep us guessing and asking questions that the same people who take a Panado and an aspirin don't even read the paper that is enclosed in the pack about side effects and other things. And they make that seem like an intelligent question when it comes to these vaccines. There are very few medications that I've taken that when I read, the directions say that there might be some contraindication. I think that's what they call it. So there is no perfect medication that works perfectly for all time for everybody. You get asked about allergies and all of these things. If you're not sure, ask your doctor. There is no conspiracy to get you to be controlled by Bill Gates. It is nonsense. In isiXhosa, it's called inzone. We must not be children and believe these fables when people are dying. It is very important that we grow up. And it is time that we exhibit a very low tolerance for these people who introduce arguments that are designed specifically to undermine the country's public health response to this pandemic when people are dying. We must be more responsible. We must be more responsible and have a higher sense of duty. If you are vigilant about what you eat, please tell me what the ingredients in your KFC are. You don't know them, but you raise these issues when it comes to COVID-19 vaccine specifically. So I will leave it there. Let's be more responsible. And please let us look out for those who are more vulnerable than we are and think about our own role in putting their lives at danger when we are not careful. Thank you very much and good evening.